Welcome to Children and Airway Assessment. Airway disorders may cause severe and at times sudden threats to a child's life. The special susceptibility of children to disorders of the airways stems from several factors. There can be congenital anomalies of the airway structure, and those can cause difficulties early in life, even when normal anatomy is present. The anatomy of a child is relatively small in the pediatric airway and puts children at distinct disadvantage. The inherently narrow trachea and bronchioles can become critically compromised by only minimal swelling of the submucosal lining or in the presence of foreign objects. Many aspects of the anatomy must be understood to appropriately support and intervene on behalf of a child during a respiratory illness. The upper airway consists of all structures connecting the mouth and the nose with the glottis. This includes the nose, nasal coronae, nasopharynx, mouth, oropharynx, and structures of the larynx. Compared with an adult, the anatomy of an infant and small child's airway contains several differences and functional limitations. For one, the epiglottis is long, floppy, and angled away from the tracheal axis. It covers the laryngeal opening because of poor support by the surrounding tissue. Structurally, an infant's larynx is positioned higher in the neck, near C3-4, than an adult's, which is at C4-5. Because of this high location, the trunk base tends to hide from view during direct laryngoscopy when you're trying to put in an ET tube. The cricoid cartilage is non-expandable. It's one whole ring, and that is normally the only complete ring of cartilage in the airway. In a pediatric airway, it's the larynx's narrowest point. With the reduced and fixed dimension, an ET tube may pass through the vocal cords and yet not proceed to the subglottic trachea. This already narrowed portion of the airway becomes severely narrowed by even small amounts of edema that can develop with different diseases. Infants are considered obligate nose breathers, and the upper airway and lung do not completely develop until about age 8. So let's review. The head is prominent. It's very large in infants and toddlers compared to the rest of the body and can cause the head to flex on the neck, the sniffing position. A folded towel should be placed under the shoulders of infants to level the plane of the airway. The tongue is relatively large, and it takes up the inside of the oral cavity in children. With loss of muscle tone, it can fall back into the posterior pharynx and result in airway obstruction. The larynx is more cephaloid in position. It makes visual or more forward, making visualization of the airway with a laryngoscope challenging, especially in the field. Paramedics have a tough time. Not only that, the epiglottis is soft. You need to use a straight blade to lift it out of the way so you have a clear field of view. The smallest diameter of the pediatric airway is at the level of the cricoid ring, and it's solid. It's at the level of the vocal cords in an adult. This difference can mean that a very small object may be lodged in a pediatric airway below the level of the cords and cannot be removed with pediatric McGill forceps. You won't be able to see it. The cartilage is softer, less calcified, which can allow the trachea to collapse with high negative inspiratory pressure or with acute bends in the neck. as can be seen in extremes of flexion or extension of the neck. Oxygen consumption in an infant is twice that of an adult on a per kilogram basis. As you can see here, in an adult, it tends to be 6 to 8 milliliters per kilogram versus 3 to 4 milliliters per kilogram in a child. Once pediatric patients become apneic, they desaturate much more quickly. Smaller airways equal higher airway resistance. We can see this in Poiseuille's law. The smaller the airway, the higher the resistance to the fourth power. So even a small amount of inflammation in a pediatric airway will result in much, much higher airway resistance than in an adult. These features, along with increased rib compliance, eventually result in respiratory failure when respiratory distress is prolonged. Due to the high oxygen demand, a healthy child desats much more quickly than an adult, and you can see that here in the graphic. We have the only thing that will desaturate more quickly than a normal child is an obese adult. Signs of respiratory distress: tachypnea, stridor, retractions, head bobbing, and nasal flaring. Respiratory failure. Respiratory failure is defined as either inadequate oxygenation or ventilation or both. Most children initially present with respiratory distress and hypoxia. Hypoxia alone does not constitute respiratory failure unless the patient remains hypoxic despite your interventions. When a child has respiratory failure, you may see altered mental status, poor respiratory effort, low breathing, low heart rate, and apnea. Respiratory failure equals inadequate oxygenation or ventilation. Let's talk about airway obstruction. There are 3 types of airway obstruction. There's croup, a viral infection of the airway below the level of the vocal cords. Epiglottitis, an infection of the soft tissue in the area above the vocal cords. And foreign body airway obstruction. This is from an aspirated object in the child's airway and can cause either partial to full obstruction. Signs and symptoms: decreased or absent breath sounds. Stridor. This can be inspiratory, expiratory, or biphasic stridor. The most common is biphasic stridor. Retractions. Difficulty speaking. Signs of severe airway obstruction include ineffective cough or no sound, inability to cry, increasing respiratory difficulty with stridor, cyanosis, a late sign of hypoxemia, and loss of consciousness. These are true emergencies. This is the end of the presentation, and I thank you for your time and attention. Have a great day.